Hello, I'm honored to be speaking with you today about peer support services that are being used across the United States to address the health and wellness needs of people who live with mental health challenges. This presentation was developed by a dissemination team comprised of leaders from the Chicago Health Disparities Center at the Illinois Institute of Technology and the National Association of Peer Supporters, also known as INAPS. The Chicago Health Disparities Center is a group of investigators and persons with lived experience of mental health concerns that examine the health and wellness needs of people living with serious mental illness. The team also examines the barriers caused by public stigma and self-stigma. The ultimate goal of the center is to improve the quality of health while simultaneously eliminating the stigma that affects the health of persons living with a mental health challenge. Serious mental illness is defined as a mental health concern that hinders the individual from achieving their specified life goals. INAPS is a national organization whose mission is to grow the peer support profession by promoting the inclusion of peer specialists throughout healthcare and other community systems. This presentation is based on a view of hope and recovery for all. My name is Martha Barbone. I spent 12 years in the U.S. Air Force before being sidelined by a diagnosis of depression and PTSD. After several years, including multiple hospitalizations, medications, and other treatments, I was introduced to peer support. This led me to a newfound hope and discovery of inner strength. I directed the Certified Peer Specialist training in Massachusetts for 4 years. I have also worked as a CPS on an inpatient psychiatric unit. In a peer-run organization, I facilitate peer support groups for the Veterans Administration, and I'm currently the interim director of operations for INAPS. It was a big shift for me to go from a person who was just a recipient of services to someone who was actually a member of a team participating in my care. This also sparked my interest in research, and I have been fortunate to be involved in several research projects. Participation in these activities has given me a greater awareness of the research community, and I've been fortunate to share my experience and be included in planning for future research. I look forward to sharing information on participatory research with my community and with you today. I have nothing to disclose and no conflicts of interest. This presentation will review the value of peer support providers based on PCORI-funded research in assisting people with mental health challenges and attaining their health and wellness goals. PCORI, or the Patient-Centered Outcomes Research Institute, supports research that helps people make informed healthcare decisions and improves healthcare delivery and outcomes by producing and promoting high-integrity, evidence-based information that comes from research guided by patients, caregivers, and the broader healthcare community. PCORI is a United States-based non-governmental institute created as a result of the 2010 Patient Protection and Affordable Care Act, also known as the ACA or Obamacare. Development of presentation materials, as well as the Speakers Bureau doing this presentation, is made possible by a Eugene Washington Award Dissemination Initiative proposed by the Chicago Health Disparities Center and the National Organization of Peer Supporters. Please note, all materials and comments in this presentation are solely the responsibility of the dissemination team, the Chicago Health Disparities Center, and the National Association of Peer Supporters. PCORI is not responsible for the presentation of these materials. So why are we talking about this? Statistics have told us that people living with serious mental health challenges get sick and often die 10 to 20 years younger than their cohorts of the same age. This pattern is even worse if the person is of color or from a low-income community. Peer support services are an effective way to assist this group in achieving their specified health and wellness goals. These are the objectives of my talk today. First, we're going to identify the problem, which is that people get sick and die younger, people who have mental health challenges, and they have reduced access to care. Second, we'll talk about peer support services as an effective solution. Then I'll describe one program that involved community-based participatory research, or CBPR. We'll then discuss 3 PCORI research studies and their findings. Finally, we'll have time to discuss how peer support services might be implemented moving forward and how to overcome barriers to that. So let's look at the primary issue, which is the health and wellness needs of people living with mental health challenges. In the last several years, we have seen a move from a illness-based, maintenance-based system to a system that is more recovery-focused. And when we talk about being recovery-focused, it's that people can still be in touch with their hopes and dreams and aspirations for the future, even if some of their symptoms remain. Symptom control alone is no longer considered enough. We believe a recovery is possible for everyone, and we are developing programs and training providers to assist people in attaining the goals they choose, with hope and empowerment key to that. What I'm presenting is evidence-based, and the evidence comes from several organizations such as these: the NIMH, CDC, SAMHSA, PCORI, and the National Academies of Science. So when we talk about the physical health concerns of those with mental health challenges, what exactly are we talking about? So as you can see from this slide, almost every organ system may be affected in someone that has a mental health challenge. I think people are well aware of increased cardiovascular disease and often accompanying obesity. We also see GI disorders such as ulcers due to stress. We see more infectious diseases and communicable diseases, and sometimes this is connected to unsafe sex practices. We see orthopedic injuries when people are unstable on their feet. We also see more cancer, more neurologic disease, more respiratory ailments, and more kidney ailments as well. People living with mental health challenges visit the emergency room for their physical health care far more than their peers who do not have mental health challenges. They often have decreased mobility, affecting their ability to meet their personal goals related to education, work, or independent living. They may end up in an institution, such as a state hospital, a nursing home, or other 24-hour care facility, where their needs are met for things they cannot provide for themselves. And as we said before, this group gets sick and often dies younger than their peers who do not have mental health challenges. The results we would like to see are wellness, and by that we mean an increase in quality of life, an increase in inner peace, serenity, and a sense of calmness, an increase in the sense of wholeness, rather than a sense of or feeling of inadequacy and brokenness. So let's define what we mean by serious mental health challenges, or sometimes called serious mental illness. Serious mental health challenges, such as a diagnosis of schizophrenia or bipolar disorder, are oftentimes accompanied by a substance use issue, and this is what we call co-occurring disorders. People in this group often have difficulties achieving their specified goals in relation to education, employment, independent living, developing good relationships, and their overall health. This is different from Social Security's definition, which is solely based on the employability of an individual. We're talking about individual having a quality of life, whether or not that includes employment. So what makes health outcomes worse in this group? We know ethnicity affects health outcomes, and people of color have worse health outcomes than the white population. People who are poor have worse health outcomes, especially when that leads to homelessness. Victims of crime have worse health outcomes, especially, and as do perpetrators of crime who become involved in the justice system. And those who abuse substances also have worse health outcomes. We're going to go through 6 reasons why this occurs. The first is lifestyle. When we talk about lifestyle, these are typically modifiable behaviors and risks that can be changed if one chooses and has the right support. We know diets that are lower in fats and sugar and higher in fresh fruits and vegetables improve health. Exercise and even walking 20 minutes a day can improve health. We know that smoking is a big risk factor for all kinds of health problems. Unsafe sex can result in communicable diseases. And we know people that use substances have worse health outcomes. Next, we're going to talk about the social determinants of health. We've referred to some of these already, but with poverty is limited income, also limitations to other resources, such as health insurance coverage. And those and often when it leads to homelessness or insecure housing, those people have even more hurdles to face. People in this group often are the victims of crime, especially robbery and assault, and also may experience more domestic violence. People in this group also find themselves involved in the criminal justice system more often, and there is often inadequate support. Now we're going to talk about another reason, which is the fragmented healthcare system. This is due often to insufficient resources. There are too few primary care clinics, and they might not be in a neighborhood where a person lives. And there are even fewer specialty care clinics. And these clinics, even if they are available, may be inaccessible due to a lack of transportation or inability to use the transportation that is available. Insurance plays a role in the fragmented healthcare system, with some coverage having too few entitlements and a lack of parity or equity between physical healthcare coverage and mental health care coverage, with often mental health care not getting as many benefits. And even when there is healthcare coverage, there's often a lack of recovery resources in that coverage. There's also a general lack of culturally relevant services. By this we mean people unable to get care in the neighborhood where they live. And if I am seeking care, I would be much more comfortable with a person who looks like me and talks like me. And often often providers of different ethnicity are not available. And services often fail to reflect the cultural priorities of the individual, including a culture of hope and recovery that is relevant in that culture. We also talk about medication side effects, or as I like to say, other effects. Medication has the desired effects and the undesired effects, but they are all medication effects. We know that weight gain is often seen, especially with atypical antipsychotic medication. And this can lead to type 2 diabetes, high blood pressure, and cardiovascular disease. It also results in decreased motivation to modify behavior. And there's also genetic comorbidities or propensity to develop other diseases such as heart arrhythmias, autoimmune disorders, and diabetes. So we've talked so far about the problem. Now I'd like to talk about peer support services as one solution. Peer providers are persons with lived experience who may be from the same community, many times the same ethnicity and or cultural background, who provide practical assistance and support to individuals in achieving their recovery goals. For most physical health problems, treatments do exist. We have many evidence-based strategies that are those that are proven effective through rigorous study and evaluation. We have amazing training programs for doctors, nurses, therapists, and now for peer support providers. So why do we still see so many physical health issues? One solution to the fragmented system has been the development of integrated care, which is one-stop healthcare for primary care, specialty care, and mental health care. Unfortunately, this promise has not been realized across the board. Some providers still have the attitude that they don't want or can't treat mental patients in their clinics. Often funding is not available for adequate integrated care services, and recovery services and resources are often lacking in this system. Paraprofessionals are one solution as well. Community health workers are from very diverse backgrounds, and they often are living or have lived in the community they serve. They're diverse in many ways with respect to gender, ethnicity, age, sexual orientation, and they address a wide range of health goals. They might support someone around smoking cessation, weight loss, diabetes management. They may transport people to appointments and empower them and advocate for them in those appointments. And they may provide a lot of health education about a person's symptoms and their illness and their medications. Community health workers meet people where they live and work. Another type of paraprofessional is patient navigators. Patient navigators originally came about in the breast cancer community when patients were traversing a maze of services to get breast cancer treatment in a hospital. Support included emotional support as well as practical support, such as transportation and figuring out insurance entitlements. These peer navigators evolved from what was first provided by professionals to paraprofessionals and volunteers. And they were part of the peer group. They were people from the same ethnic group and often cancer survivors themselves. Most importantly, they offer emotional support through empathy of having been there. So what I'm really going to focus on is peer support services. Peer support started as part of the self-help movement or development of mutual support groups. These groups were often in peer-run organizations and started and run by volunteers. And what we've seen is the movement to hire peer specialists into the behavioral health care environment. And now peers are providers of care. They are not clinical providers. The support they provide is based on mutuality and their own lived experience. There are several basic values all peer support specialists have, primarily that they are recovery focused. We are accepting of where individuals are, and we don't use force or coercion to get them to accept treatment, accept a diagnosis. We meet them where they are and work with them based on their wants and needs. We empower people to be involved in all their healthcare decisions. We focus on an individual's strengths as opposed to focusing on their illness or what's wrong. And we provide the support in the community of their choice. It might be their home, it might be in a coffee shop in the community, it might be on an inpatient unit, but it is always at the choice of the individual we're supporting. The key ingredient to peer support is self-disclosure or sharing our story. When we share our story, we talk about some of the challenges we've had, which is sometimes called when we were down. Then we talk about our own recovery, what we found that helped us move on through those challenges and have a full life. We share what's worked for me, and we may share what we've heard's worked for others. We don't ever say, this is the way you need to do it because this is how I did it. But it's to offer opportunities and help someone find what works for them. There are also limits to disclosure. We don't have to tell our life story when we share our story. We share what's comfortable for us to share and what's important in that situation to make a connection with the individual we're supporting. So what are some of the things peer specialists do? We promote shared decision making. We also may teach skills. And we also support people to navigate this fragmented healthcare system. So let's talk a little more about shared decision making. Good healthcare services promote hope, self-determination, and empowerment. But there has been this underlying question: can people with serious mental illness really make these decisions? The answer is yes, if they're given enough information and enough support so that they feel empowered to be involved in their care. Peer specialists are a prime demonstration of this, as most of us were once in the system and now we're out working and supporting others. Shared decision-making is a healthcare standard that everyone involved in healthcare is involved with. So how does a provider support shared decision-making? They help a person understand. They help a person understand their illness and maybe their symptoms, and they also listen to understand what the goals of the person are. They may give information on a full range of options given to reach those specified goals. And they use person-centered skills to help a person make the decision that is best for them. So what do peer specialists do? Sometimes we teach skills. We help a person identify what skills they already have and what skills they would like to have. With the end goal being self-management. So what is needed for this? One is information. A person needs to fully understand what is going on, and this information needs to be provided in the type of language a person can understand. When we talk about behaviors, it's what can I do as an individual to improve my healthcare outcomes? And we also help a person access the system or be given the opportunity to get the care that they have chosen. So what are some types of information that peer specialists may help? Often we help someone create lists of questions to discuss with their provider. What exactly are my health challenges? What are the options for treatment? If I choose an option, how do I get access to that? Does my insurance cover it? Will I have to travel? Part of this is also identifying wellness goals. And often treatment goals are not wellness goals or life goals. Ideally, my treatment goals help me toward my wellness and life goals. And then once I've decided that's my goal, how will I achieve it? These are very important discussions that peer specialists have with people they support every day. So we talk about behaviors. What do I need to achieve my health and wellness goals? In the introduction, I said I had moved from when I was once just a recipient of service to participating in my healthcare. When I was a recipient of services, I thought healthcare and treatment was something that happened to me, and I just sat passively and received it. You know, I took my pills. I did what I was told. But there are many things I can do to improve my own health and wellness. I might want to learn how to deal with stress and what tools I can learn to manage my own stress. If I'm taking medication, I might want to learn more about that and learn ways I can better manage my medication and better ask questions about my medication. I may want to choose to eat better, and I might need help figuring out what eating better really is and how I get access to those type of foods on a limited budget. And I may want to increase my physical activity. It might be walking every day, or it might be trying to figure out how I can use a gym. And then there's opportunity. Once we've gone through all this, we support people to use the skills in their world and make sure they have the opportunity to get the best treatment that they have decided on. We may go with them to appointments if they have asked us to. Sometimes we'll do things like shop together and even cook together. We may participate in wellness programs in a person's community until they're comfortable to do it on their own. What this all comes down to is navigating the community. This map is of Chicago, and this is just to demonstrate what we mean when we talk about a fragmented healthcare system. As each red dot pops up, that is a different location someone would have to go to get services. So you can see, without integrated care, it may be physically impossible to attend more than one appointment in a day, or even in several days. It may mean taking a whole day off work for one 15-minute appointment. It may mean having to learn to navigate a complex public transportation system or find another means of transportation. If someone relies on a friend, they have to rely on that friend's schedule as well. So fragmentation is a big barrier to adequate care. Part of navigating this system is first finding the services, then getting an appointment in the service of a person's choice, traveling to the appointment, and finally interacting with the medical professional. Often when we get in an office with a doctor, we may have all kinds of questions we want to ask, but I really wonder how many people ask every question. And what is the barrier to asking those questions? I know for myself, I may have a question, but I may be thinking, gee, if I ask that question, I'll sound stupid, or the doctor will think I'm being argumentative, or their time is really important, and so I shouldn't take up their time asking questions, as there are people far sicker than I am that need their attention. So we support people to be empowered to get the most that they can out of every appointment. And this is all done by what the person chooses for us to support them with. So when we talk about the basic skills of peer specialists, the primary thing is number one here, listening. We don't go into a meeting with someone we're supporting with our own agenda. We need to listen first and find out what is important to that person on that day. Then once we have listened and heard what they said, we can respond to their concerns. We also have to manage our own role and our own role limitations. And we have to be transparent about that with people that we're supporting. We have to let them know what we are able to support them with and what we may have to refer them to someone else to get accomplished. So these are some of the skills of peer specialists. One, we all have active listening skills. I'm not going to go into depth what that is, but really listening with an intent to hear and asking questions of that person to fully understand what is important to them. We may help them with goal setting if that is what they ask. Often peer specialists are taught motivational interviewing. For me, motivational interviewing is an ideal tool if it's used right. Unfortunately, I often see people say they're going to use motivational interviewing to get someone to accept what's important to the person doing the interviewing, whereas we're using motivational interviewing to help the person identify what's important to them and then accomplish a goal. We offer support through a strengths-based model. And we do advocacy. And by advocacy and peer support, we don't advocate for others, we advocate with others to the best of their ability. When we talk about responding to someone's concerns, it might be around problem solving, or someone might be concerned about relapse. The word relapse I find more associated with substance use, but it can also be, what happens when, my mood gets low. We know recovery is not a straight line and there's ups and downs. We may talk to someone about harm reduction. And we often talk about crisis management or what you're going to do when you feel overwhelmed and you want extra support. And we always concentrate on providing trauma-informed care. And this is the shift from focusing on what's wrong to building a relationship based on trust, choice, and collaboration. When we talk about managing our own role as peer specialists, part of that is self-disclosure, what we're going to share in our story to make the connection and to be supportive in that relationship. We also need to be transparent about relationship limits and the difference between a peer support relationship and a friendship. And we need to take care of ourselves to avoid burnout. This is particularly high in all healthcare professions, but for peer specialists, we're working with people who we see a lot of reflection of ourselves in that, and we need to be cognizant of that and get the support we need to avoid burnout. We also often use what we'd call street smarts, our own experience in the system to help us navigate particular areas of the system. So I'm going to move on now to community-based participatory research. So community-based participatory research, CBPR, the main idea is that underrepresented individuals should be involved in all phases of research to help reduce unfair barriers. By all phases of research, we're talking about developing the idea, even the hypothesis, what's going to be researched, then developing research methods, collecting data, analyzing data, and, as in the case of what I'm doing today, disseminating the results of research. CBPR is collaborative, and each person involved brings their own unique strengths. And it's about bringing research that is important to the community and will improve the healthcare outcomes in that community and eliminate any disparities that may have been around. The Inspiring Change Project is a project that was created to address healthcare obstacles by involving African Americans with mental illness in all stages of the research project. This project was done in 2015 by the Chicago Health Disparities Center. They developed a workbook for those that participated and then developed a manual for trainers. The model of community-based participatory research here was including persons with lived experience, academic researchers, and people from the community, including service providers and other community stakeholders at all stages of this program. So I'm going to go through an example here. The first was understanding the problem, and the research question was, why is emergency room use so high in our community? And this group decided that to answer this question, they will survey people who use the emergency room. And that's how they gained an understanding of the problem. Next, they wanted to design a solution. So the research question proposed was, how can we use research to create a nurse helpline that will help people, that people will use instead of going first to the emergency room? And the method they chose was to survey emergency room users again to find out what this helpline would have to look like in order for people to use it, and then to develop a training program for the nurses who would staff the helpline. And then they tested the solution. And to test the solution, the question was, how effective is the nurse helpline for avoiding emergency room visits? So to answer this question, they had to actually measure changes in emergency room visits after the helpline started compared to how it was before. From this came the Inspiring Change leadership training. They used PCORI resources to develop a leadership training manual for people with lived experience to become full partners in this research project. They had a 2-day workshop for this training, and the best part of that was being able to network with each other both during the training and after the training. The topics included in the training were this introduction to what CBPR is, different leadership styles and communication skills, how to be a project manager or lead a meeting. Self-care was included, as well as mentoring, where more experienced trainers would mentor the new trainers. And they also discussed solving problems and managing conflict. I'm now going to talk about PCORI research findings. This slide I know is rather busy, but these are 7 PCORI funded studies that we looked at that we didn't include. We were looking at studies that included peer support for people with mental health challenges, and we also wanted to pick studies that were completed. If you want to know more about any of these, I'd encourage you to contact the principal investigator or check the PCORI website. These 5 studies met all of our criteria. 2 of them are still ongoing. So today I'm just going to talk about the 3 completed studies. The first one is called the Bridge Program. The question was, can people who have experience with serious mental illness help peers manage their health care? This study was, the principal investigator was John Breck at the University of Southern California. They tested the Bridge Program versus treatment as usual. So the Bridge Program taught peer navigators to train others to navigate the system. They used motivational interviewing, education, modeling. The treatment was done face-to-face in the clinics. The peers were all people in recovery as the teachers, and they taught skills to create better availability to healthcare. And this was a 6-month program. There were 151 people with serious mental illness randomly assigned to one of 2 groups, the mental health care as usual, which was the control in this case, and the Bridge Program plus mental health care as usual. Data was collected at the baseline 6 and 12 months. The measures included the number of routine care visits, the number of routine health screenings, and the subjective quality of relationship with the healthcare provider. and the person's confidence for their own self-management. They also measured persons' health concerns with regard to chronic disease and pain. This graph shows some of the results. The slides represent changes from baseline to 6 months reported by research participants in the bridge group, which is orange in this slide, versus the control, which is the white dotted. Findings here are reported as change scores by subtracting a person's score at baseline from their report at 6 months. Note that there is significant improvement found for the number of routine visits and the number of routine screenings from baseline to 6 months. The quality of relationship measure is reverse scored such that more negative change scores from baseline to 6 months actually represent improvements in a perceived relationship. Findings in this graph shows those in the bridge group have a better relationship than those in the control group, although this difference was not significant. This graph shows change in perceived confidence in managing one's healthcare. Note a significant improvement for people in the bridge group, while those in the control group actually showed worse confidence. This final graph shows changes in concerns about chronic disease and bodily pain. On the left, you can see people in the bridge group showed significant improvement in chronic disease management concerns, while those in the control group were actually more concerned. In terms of bodily pain severity, this index is reverse scored, such as the negative change scores mean less perceived bodily pain. Once again, we see significant improvement in perceived pain for the bridge group compared with the control group. This research was done as a partnership between the University of Southern California School of Social Work and Pacific Clinics. Go to this website to learn more about their health navigation training program. The second PCORI-funded study was conducted by Dr. Patrick Corgan from the Illinois Institute of Technology, titled Peer Navigator Support for Latinx Patients with Serious Mental Illness. In an effort to be fully transparent, Dr. Corgan is also the principal investigator of the overall dissemination grant supporting my presentation today. This study developed a peer navigator program called the PNP using community-based participatory research. Peer service providers were Latinos or Latinas in recovery and living with a serious mental health challenge. They helped research participants to better engage in health services. In the process, research participants were expected to better address their health goals. The key element of the PNP was to literally walk the service recipient around the complex and fragmented healthcare system. This was a 12-month program. 110 persons with serious mental illness and current physical health concerns were randomly assigned to the PNP or to the Integrated Care as Usual group. Data was collected at baseline, 4, 8, and 12 months. The measures included service engagement, which was measured by achieved appointments, and perceived effects on health, including perceived recovery, empowerment, and quality of life. This graph examines how monthly achieved appointments change over the 12 months of the study. Scores were adjusted by the age and place of birth of research participants. By place of birth, we mean whether the individual was born in or outside the United States. Results showed a significant interaction, which suggests a steady increase in achieved appointments for PNP compared to the control group. This finding show a clear interaction with steady improvements in self-reported recovery for those in the PNP group as compared to the control group. Here the PNP is the black dotted line, whereas the control group is the orange solid line. The empowerment measure is reverse scored. So lower scores represent more empowerment. Once again, there's a significant interaction where PMP empowerment improved over the course of the study, while the control group was steady or did not improve. This last graph shows changes in quality of life from baseline to 12 months. Once again, steady and significant improvement is seen in the PNP group, while quality of life in the control group really did not change. This research was done as a partnership between the Chicago Health Disparities Center at the Illinois Institute of Technology and Trilogy Behavioral Health. Here is the website to learn more about their health navigation training program. The last PCORI funding study I'll discuss was led by Cheryl Bellamy from Yale University, titled, "Does a Peer-Led Program with Wellness Coaching Improve Wellness Among People with Serious Mental Illness?" Using community-based participatory research, this group developed the Peer-Led Wellness Coaching Program. Peer-Led Wellness Coaching Program was a 6-month program and included 3 months of peer-led groups educating participants on personal wellness, stigma, and self-management strategies. In addition, program participants received 6 months of individual wellness coaching offered by a peer provider. Sorry, I've gone backwards here. Get back on track. So there were 74 people with serious mental illness enrolled in this study. It was a quasi-randomized design. 37 were assigned to the peer wellness coaching, and their scores were compared to 37 others who received treatment as usual. Data was collected at baseline, 4, 8, and 12 months. Measures included the number of emergency room visits, participant-reported changes in alcohol use. General wellness measured how participants perceived their overall wellness. Data was gathered from participants on their input and decision-making into their treatment plan. Finally, it was evaluated whether they reported greater treatment satisfaction. This graph does not represent exact data, but demonstrates the general trends between the two groups. Compared with participants who received usual care, participants in the program showed fewer psychiatric or substance use emergency department visits, greater decrease in alcohol use, greater improvements in general wellness, more treatment plan input, and greater treatment satisfaction. So finally, I want to talk to you about moving forward. How do we implement peer support services? What are the barriers and how do we overcome that? Some of the barriers to implementation is that it requires a significant shift in culture. This is both in culture from providers and from people receiving services. It would involve identification and selection of a workforce, training and certification of that workforce, supervision of the workforce, program evaluation, and finally, how are we going to pay for this? So let's think about this shift in practice culture. And like I said, there's a culture shift on the part of providers and on the part of service recipients, where it has always been where someone came for services and they were sort of the recipient and the expert gave the services. Now we're talking about a more collaborative effort. I'll give you a moment to think about how you would see this culture shift come about. One thing that comes to my mind is having people with lived experience speak at provider meetings so they get firsthand experience of what we're talking about and see actual peer providers and what they bring to the table. One barrier might be training and certification. Right now, every state has unique requirements for peer specialist certification. What is required where you are? How much time is required? What cost is required? Is it accessible? Is it only in one location in the state? Would people have to travel to get the training, or can the training be done locally? Is it all in person, or can some of it be done remotely? Along with initial training and certification, we also have to provide ongoing education that is relevant. Continuing education that is available for licensed professionals isn't necessarily what this group needs for their ongoing education. Then comes supervision. Who's going to supervise these people? Supervision is supervision. There's basic supervision that applies to everyone, and supervision of peer providers is no different. They have the same expectations to show up for work, do what their job entails. But to supervise this group, you have to have a very good understanding of what their role is and how their role might be different from yours. INAPS has developed supervision guidelines that go along with the National Practice Guidelines for Peer Support. This could be one resource. Intentional peer support has a system called co-supervision, and this could be very helpful if you have several peer supporters practicing co-supervision with each other. Then we talk about program evaluation. How are we going to know if this is working? What is proof that it's working? Is it about number of visits? Maybe if it's working, the number of visits will go up. At some point, if it's working, the number of visits may go down. We have to have fidelity to the model. If we're trying to evaluate if the program is working, we have to know that we've enacted it with fidelity to the way it was supposed to be done. And we might be looking at different outcomes. We're looking at quality of life instead of maybe absence of symptoms. How are we going to evaluate quality of life? And finally, how are we going to pay for this? How are we going to make sure these peer providers make a living wage? Often, peer specialists are looked at as people that have a certificate from a 1 or 2 week training, and they have their own lived experience, and that's all they bring. If you look at this population as a whole, these people bring a wealth of experience to your organization. Many of them have had jobs before. They may have been supervisors. They may have owned their own business. They may have been in the military. So there's the other experience of all of us with lived experience that could be very beneficial to your organization. What are other sources of funding? If insurance isn't paying for this, what are other ways this service can be paid for and be accessible? I want to thank you all for listening to this important topic today. I've enjoyed presenting it. Patrick Corrigan, who is the principal investigator for this dissemination team, I provided his email here. I've provided my email with INAPS, and I'd welcome any comments or discussion from anyone. Thank you very much for listening.